Hello again, everybody. This is Fred Kranz from St. Ange, coming to you with another episode of Taking the Supply Chain Pulse. Today, our guest is going to be Jane Pleasance, the Executive Director of the Strategic Marketplace Initiative. Jane has had a distinguished career in healthcare. She was a Bellwether League inductee from the class of 2015 with a long career in academic healthcare, which we're going to talk about today. Jane, thanks so much for being our guest.
Thank you for inviting me.
It's going to be fun. Tell us a little bit about yourself, Jane, and your career in healthcare.
Sure. So I actually started out as a teacher, and I had an interesting journey in that I ended up having 3 children about 18 months apart, 3 little boys. When I went back to teaching, I realized having kids in the morning and kids in the afternoon wasn't going to quite work for me. So I stopped and paused for a few minutes to rethink my career, which was a challenging time for me, as you can guess. And I got invited to be the materials manager for a very small community hospital, about 70 beds, and thought, well, I guess I could learn this. And I was there for about a year, and at that point decided maybe I needed to go to a larger hospital and learn a little bit more about supply chain and just be on the staff. And so that's when I started my work at Vanderbilt. And that's my entrance into academic medical centers. And I totally enjoyed and embraced the values, the culture of an academic medical center. And perhaps it aligned with my educational background as well. But that's where I got started. And then my journey has taken me from Vanderbilt to the University of Rochester, and then ultimately and finally to Duke.
Well, that's interesting because you started out in academic medical center, so you knew nothing different. When we talk about this, I came from outside of academic medical centers to doing a huge project at Vanderbilt after you had gone to Rochester. And when you walk into that environment for the first time, you're learning that things are often different there than in the quote normal unquote a non-for-profit community hospital system. But I did the math, and it tells me that if you had 3 children in 18 months, there's got to be a set of twins in there someplace.
Oh no, each one was 18 months apart.
Oh, 18 months apart.
Yeah.
Okay.
3 children, 18 months apart each one.
Okay, I'm glad we cleared that up.
Yeah.
So let's talk about your experience in academic medical centers. As I said, was Norm Ermey, I think, was probably the CEO when you were working at Vanderbilt, and it's like his retirement project. He had 2 things. He wanted to do a deep dive on the supply chain of the medical center, and they also needed money because I learned that the medical center supported the university, and I never would have thought that. It was a
school.
Yeah, it was a completely foreign environment to me. So tell us about what you did there, and did you think it was strange while you were working there? And have you found out that it was strange later? I don't know.
Well, my first goal was just to learn supply chain in an environment that I knew wasn't going to be likely bought out by any organization. That was one thing. But also I liked the idea that at Vanderbilt, we had responsibility supply chain for both the university and the health system, or the hospital at the time. It wasn't a health system.
Yep.
But what I found about the culture in an academic medical center, and this is what stayed with me through my tenure at Rochester and then ultimately at Duke, is that the physicians that you interact with in your clinical team were all part of one organization. And in other words, you sort of all were aligned to the same goal. Now, health systems have evolved a lot. They've acquired physician practices, and that, has changed a lot. But back at that time, your physicians were all community physicians. And so gathering them together to try to think about strategy and how you were going to align them to wherever you wanted to go from a supply chain perspective could be particularly challenging. But in an academic medical center, if you could get the cardiology group, or you could get the surgical services group together. There were a lot of really great things you could do together because the physicians were so aligned with your mission in that academic medical center. And it was that mission alignment that I found to be so rewarding. The other element of it was just always wanting to do something new and innovative. You know, that's the way academics are. Research drives you that way. And so you had to be somewhat willing to kind of step out there and do something new and innovative, because that's where your clinical team's heads, go every single time in an academic environment. Again, as these academic medical centers have become health systems, some of the culture has changed, but certainly back then that was the case.
What was interesting when I got there was that clearly the hospital supply chain, if you will, and it was the hospital, reported to the supply chain leader for the university, and I was about, I don't know, 3 or 4 years, maybe 5 years ago. I was at a meeting and Teresa Dale was there, and as you know, Teresa Dale runs Vanderbilt's supply chain now, and she said in a formal setting, she said, I really need to thank Fred Kranz because of him I have my job. And I said, Teresa, what do you mean? And she said, well, I understand that when you were here with Accenture, that you got asked by someone what your opinion was of the healthcare supply chain, and your response was, you don't have a healthcare supply chain. You have a supply chain that reports. You have a healthcare organization that reports to the university supply chain. If you want to have a healthcare supply chain, you have to establish one. And she said, because you said that, they made the changes that brought George, the fellow from Orlando that she worked with, and then her. Did you notice? I found out when I was at Vanderbilt how much money they spent on concessions for the football games. That's the kind of information that we were going through, trying to figure out things about the healthcare operation. Do you think that setting those things up separately was ultimately a good thing for Vanderbilt?
Well, certainly at the time, given whatever was the driving force of that, it was. But what I will, if you take a step back and you think about you're sitting on a campus, and I'm not speaking to Vanderbilt, I can speak to Rochester and also to Duke. Your organization is sitting on a campus, and you have vendors that are calling for you, and if you calling on you, and how do they know often which contract, which service they're actually working for? And there's this huge overlap. In fact, as I looked at it when I was at Duke, the overlap between the vendors that did business with the health system and the university were huge. In fact, that volume was close to, if you removed drugs and medical devices out of the spend, you would find that there was more spend that was aligned than was not. So if you're thinking strategically and you're trying to aggregate volume, and the culture allows and works together as partners, you can do really good things. The other element that you have to consider is whether or not you have a shared procurement system or ERP.
Mm-hmm.
And boards, trustees are always asking, how can you have two separate ERPs and the cost that's associated with it? So if you're able to realize and accept that the culture, the procurement and supply chain on a university campus is entirely different than the procurement and the supply chain on the health system side. That's research procurement is even different because you've got federal grants you have to comply with. So if you can put on all those different hats and work through the different cultures and still bring them together where they have common interest and common spend, then you can thrive in that kind of environment. But it's not without a lot of work, no doubt.
Well, you just brought something up that I'd forgotten about, and that was, the way our contract was structured, they were trying to hit a certain goal. I think it was $19.5 million they wanted to save. And so our folks just went at it. And one of the biggest savings that they identified conflicted with research. And it was like a huge savings. It may have been $4 million, something like that. And it got dropped right in its tracks because it was a conflict with the university with some research agreements that were out there. That was a difficult learning process for me. I mean, I would never have considered that working in just regular um, private healthcare. But um,
Well, I think that's a great example, and at times that does come into play. But if you have one head of the supply chain, you can manage through those particular nuances that you're faced with. But it does go back to the fact that those cultures are very, very different.
yep. So
I
so
mean, the
you're at
same kind of tool supply chain tools don't necessarily work in an academic research environment. You don't have perpetual inventories very much in research and in the university. So you have to think about, as you're developing out your tools, how are they meeting the procurement and the supply chain needs of each of those groups?
yep. So you sort of had a building block career if you think about it. You went from Vanderbilt to the University of Rochester. So how did you take what you learned at Vanderbilt to Rochester, and what were the challenges there?
So what I would have to say is the cultures are very, very similar. Each one of those academic medical centers have their uniqueness, but at the end of the day, you've still got the medical school, you've got academic research going on, you've got medical research going on. So I think getting the exposure to a lot of different kinds of technologies when I was at Vanderbilt was huge. I'm not sure, Fred, if you remember, but they had a major partnership with ESI and we had co-developed different kinds of point of use technologies back then together. And so I had learned an enormous amount while I was at Vanderbilt. From just in time, we implemented a stockless inventory system to all of the technology that we implemented. So when I went to the University of Rochester, I had that background and that experience. I think what was the experience I gained at Rochester that helped me when I went to Duke was that Rochester was one of the very first academic medical centers that actually became a health system. And that was almost unheard of, as you know, because most academic medical centers and the hospitals were standalone.
Right.
And the University of Rochester, well before most all other academic medical centers decided to become a health system while I was there. And so I got the experience of merging and acquiring community hospitals with academic medical centers. And when the call came for Duke, that was the experience that I was able to lean on when I came to Duke, because I think I was the second health system employee at Duke when it became a health system.
So once again, your building blocks were you learned different things at Rochester. You actually what happened at Rochester. And by the way, I was born and raised in upstate New York. I'm from Corning, New
Oh,
York, which is about 60 miles from Rochester.
uh-huh.
But you sort of learned systemness for the first time at Rochester, and then you went to Duke. And without being overly complimentary, you built a real powerhouse at Duke. I mean, you came in there and built that into a prestigious um, healthcare supply chain operation. How did you go about
Thank you.
building? How did you go about building? Um, and I'm thinking back to Vanderbilt before Teresa, and I'm thinking, I don't know about Rochester, but at Vanderbilt, the supply chain was pretty much a transactional support service. It wasn't a C-suite operation. And I don't know what it was like at Rochester. But during your career at Duke, I know you built the organization to where you were an integral part of the C-suite. And one of the key challenges I see out there across our whole industry is a whole lot of people want to use titles to sort of to sort of substitute for actually having credibility. You built credibility. How did you go about building credibility to the point where the supply chain got elevated to a C-suite level operation?
Well, thank you. Thank you for the compliment for sure. But it was a team effort from day one. I think that back in that day, you're right, it was hard to get even a vice president title. So you hired as a director or maybe an executive director during those years. And I will tell you that I had a strong feeling and a sense about the need to be able to report to a very senior executive if I was going to be empowered to do the work that I knew I was going to have to do, because it was a brand new academic medical center trying to become a health system. So on one level, I thought a lot about the reporting relationship to be sure that it would be right for me to be able to get done the work that I needed to do. And I shared that with the executive team when I interviewed for the job. And I said, who I report to is going to make a difference, I believe, as to how people will pay attention to me starting something brand new in an organization. They've never shared contracts before or built anything from a health system point of view. And so they listened to me, fortunately, and had me reporting to the executive vice president when I arrived, both the executive vice president on the university side and the executive VP on the health system side. That was enormously helpful. And then the next thing that I think got the C-suite connected was I immediately created a governance board, if you will, of the COOs of each of the hospitals that I knew were going to be impacted. And so I had the COOs all around the table for all of the design, the ideas, bounced off everything we were going to do, to be sure that I had their buy-in as they went back to the hospitals and to their CEOs. And that went a long, long way because, again, I was working with fabulous leaders who had no experience in health system integration at the time. And so by bringing them on board to know the strategy, be part of the development of it, and then they would tell their folks and lead their organization to say, hey, you need to be a part of this supply chain group that's going to be doing this work. So I escalated the strategy and the work at the highest level of the organization before I started out on it to gain their buy-in and frankly to also understand where the barriers might be. Of some areas maybe I shouldn't step right into because, of course, I was brand new there as well. So having a governance board to help you, I kind of called it, of chief operating officers or very senior executive leaders is super helpful.
Well, what's interesting is that, I always think that the reason that leaders become C-suite level leaders is because they create personal credibility with the senior leaders at their organization. And I know a lot of bright people that never bothered to do that. And I know other people that that did it and couldn't live up to it once they got there. They didn't really have the skill set. You managed to do things right. Who were your mentors and what kind of, because none of us can do this on our own. So who were your mentors? Who helped you learn how you needed to do the right things to gain that credibility?
So very interesting question, Fred, because when I arrived at Duke, Tom Hughes and Concepts in Healthcare had been there to do a GPO analysis. They were already going through that process when I arrived. And as you know, Tom, when he would finish up a project, you became a part of his IDN group, if you will.
Right.
And it was really through Tom's group that I began to meet people like John Gaida, who was at Partners. He was trying to bring the Brigham and Mass General together. And I developed the relationships with people who were doing this work, who were just open and sharing with me what worked, what didn't. And I relied heavily on again, that SMI group that came together at the very beginning. Now, I was already 4 years into to Duke, but Tom had introduced me. He had the Network of Networks group, and he immediately introduced me to them, and I was a part of that group. And then the ones that were in academic medical centers and the ones that were already trying to work on integration, which was very brand new back then in 2000, they openly shared with me their mistakes, as well as their wins. And really, I'd have to say there was a good number of them, John Gaida being one, who really shared with me a lot about what was going on in Boston at the time.
Yeah, and if you look at the Bellwether League, I think Tom Hughes put more of us in the Bellwether League than anyone else out there. That's just my
Mhm.
opinion. Um, he uh, he was a brilliant person in knowing who had the skill sets, and if you got promoted by Tom, if you were given a push by Tom, that meant that you should feel pretty good about yourself. I mean, uh, and that sort of takes us to the next step, which is that since 2004, you've been active in SMI. And we know that Tom and John Gaida, among others, and Carl Manley and a few of those folks were the founders of SMI. Tell us about SMI, its origin, its membership, and its mission, if you would.
Sure. And yes, I have to, when you were asking about mentors, I'd have to go back and say Carl was one I leaned on a lot as well. And, that was that group was called the Network of Networks. And I don't know, I guess there was probably about 100 folks in there. They were all
I
people that
was.
Tom and Fred, you were there. They were all pretty much organizations that Tom had done consulting work. And as you know, it was all providers.
Hmm.
And I was thrilled to be a part of that group because I learned so much from all of them. And I got a call one day from John and Carl and said, "Hey, Jane, come up to Richmond. We got a concept for you." And they started to explain to me the idea of we're not going to have the network of networks any longer. We really feel that if we're going to make a difference in the industry, we need to have the industry partners there with us. And of course, that message resonated in a big way. It was also that it was not going to be a transactional environment, meaning no one's going to be selling to each other. And of course, I totally related to that being more strategic relationships with our suppliers than that transactional world, and removing the selling out of the environment. How might that change for the interaction between industry and providers? So I said, it sounds fabulous. I was a little skeptic because I thought, who's going to pay dues and be a member of an organization when they can't have a booth and can't sell? Because we didn't know any other concepts. So I drove to Richmond, and there were, what, 8 of us or so. And, they shared with me the idea, and I said, Duke is all in, and yes, we'll be one of the founding members. And I loved the idea that we could have, these great conversations without feeling like we had to sell in that moment. Now, what I will say is the respect in the trading partner relationship transcends past the in-person forum. Because, as you mentioned, we started in 2004. It gave me an opportunity to get to know my peers on the provider side. I knew every time I would go to a meeting, I was going to see my colleagues and my peers. On the flip side, I also got to know all of the industry executives in an efficient way, but also in an environment where we weren't trying to sell to each other. So we got to know people at a whole different level. And I leaned on and relied on those relationships with those industry partners throughout the entire time I was at Duke, because in between forums, when we did need assistance, when I did need to reach out, I knew the executives at the companies, and there was just a certain respect within the SMI community that we were going to not be transactional, and we would be more strategic about the things that we did. And that just carried over So, well, the mission of SMI was to drive change in the industry around processes and the business aspect. I also feel that its mission was to change the transactional nature of the trading partner. And if there's anything that we've done, I hope that it has been that has built respect for each other, that we are more strategic and less transactional, for ultimately we get to the win when we're strategic. And generally those transactional things clear up. It's amazing how the transactional things get cleared up in a strategic relationship.
Yeah.
And so yes, the mission of SMI is to create tools and to make improvements in the industry, but it's also, I think, to continue to hold that bar high for the trading partner relationship between providers and suppliers.
Yeah, I think prior to SMI, well, even today is today no different really. Many providers are happy to partner with and collaborate with the suppliers as long as they themselves come out ahead. And
Mhm.
and that's not the way it is with SMI. With SMI, it's creating. I always looked at it as your role was to create tools that other folks in the industry could use, and that's a very noble mission, I believe. And that was Tom, and that was you, the founding group. I had been on the Network of Networks boards when Greg Firestone was still involved before John Kelly took over and changed that. So I'm very familiar with the Network of Networks. Um, but what do you hope to accomplish during your tenure as the executive director?
Well, what I hope to accomplish is to inspire the next generation to embrace the values and the principles of supply chain within healthcare. That's really important. Fred, when a lot of us got to our upper end of our career journey, if you will, we began to wonder, would SMI resonate with the principles, the guiding principles we had, would that resonate with the next generation? Because we had sort of all grown up into health system integration together. And I've been so pleasantly surprised to see this next generation pick it up and run with it, from leading councils to being on the board. So in my vision, my goal here truly is to leave this in the hands of the next generation, and that we find ways to add value in this next generation. And with that comes a lot around, I still am a believer in data and the importance of data. It is underpinning even AI. So as we continue to look to the future, how do we balance out the need of good, clean data, UDI standards, and moving forward in an AI world? And when you think about this generation that's here now, like, they're used to just looking up on their phones, right, and seeing Amazon. They don't necessarily worry about all the stuff that went on behind
Right,
what drove that Amazon experience. Yet we all know 20 years ago we were still working on UDI, right?
right,
So
absolutely.
so it's finding the value in building up that next generation so that they carry forward. And I think the Advancing Women Leaders program, the councils we've implemented have been intentional. The co-chairing of those councils, putting the ownership of the strategies to some extent back into the hands of the members, as we continue to look forward to the future.
Well, that's great. Now, I know that recently you and several other healthcare luminaries took a
Mhm.
trip to Africa.
Yeah.
Tell us about that.
Yeah, so we had a lot of things we seem to do come from just one seed and an idea. And at the board level, we were having a conversation around what could we do next. We had been excited about starting the Advancing Women Leaders program, but it was like, okay, what's next? And someone suggested that we try to give back again in another way, and how about a mission trip? And my first, I love the idea, but I said, we just can't show up over in some place and say we're here on a mission trip. But how do we give back globally? Is there a possibility? Again, it's thinking outside the box. And so I had a conversation with Justin Freed, who's one of our members, and he's the Chief Supply Chain Officer at Adventist Health. And I said, Justin, I know you travel a lot. The suggestion has come forward, could we do a mission trip? And I don't know where SMI will go with that, but this is an idea. And Justin said, hey, let me go back and think about this. I can really put some things together here. So he came back with a great strategy for us and a recommendation on going to Zambia. And Zambia selected because of our members have been had a presence there. They've got some NGOs that are on the ground, and they've also got a big focus on empowering women, and they've got some great stories to tell about that. But they also are looking to be much more strategic and targeted around equipment and supply donation. And so we went over there, had no real expectations, but we came away with, our hearts touched, as well as our minds thinking about the potential of SMI as an organization. What can we do in a partnership sort of way? And what are the best practices around how we give away all of our equipment and our supplies? Where do they go? How do we know what happens to them? So again, that was certainly not the intent. But after we visited, we visited the most rural communities where they have one table for the OB delivery table, and that has a little vinyl on it that's all torn up.
Wow.
All the way to what was considered the tertiary care, the most leading best practice hospital we went in. It was a children's hospital. I didn't see a single electronic IV pump there. All of the IV bags were gravity with those kids. And so, people can have to ride on the back of a motorcycle for an hour to get to a hospital if they're having complications with delivery, because there are no ambulances that come out that far. So it was amazing, the need that was there, but the people on the ground, the boots on the ground, really trying to be very deliberate and very intentional about what they're doing. So, we're in the process of putting the video of our journey out on our website.
Great.
And we have a small group that's coming together to start to think about best practices around what we do with all of our used medical equipment and supplies, and how do we know for sure they're going anywhere in the world that we really want them to go, and that they're being used to the best as a resource in the very best way possible. So more to come on that.
Wow, that's great. I recently I did a podcast with Brent Johnson, and when Brent retired at Intermountain, he and his wife did an 18-month mission in Oaxaca, Mexico. And you really have to admire folks who care enough to do that. So you guys have my admiration, and anything that we can do to support. I think I may have some information on a company that wanted to work on donating equipment someplace, so I will get that to you. So
okay, great. Well,
what would you like?
it was a no. We had no company sponsorship. We all paid our own way. Paid for the trip there, paid for the hotels where we stayed, because we all personally were invested in it and wanted to see something happen. So anyway, I just share that with you.
Well, that's great. So what would you like, finally, what would you like to talk about that I didn't ask?
I think I first, Fred, thank you so much for having me and giving me an opportunity to share my thoughts. I think my last word would just be as our world is changing so rapidly, and as you see so many difficulties of people getting along, I feel like healthcare has an opportunity to come together and set an example, because we have one mission, and that's patients. and taking care of our patients. And that's the beauty, in my opinion, of the healthcare supply chain, is that whether you're a vendor of services or goods, or you're the provider providing patient care, the patient's at the end of this. And if we can continue to stay engaged and working together in ways that support each other, we'll consider to really keep the patient at the center of everything we do.
Well, Jane, I agree with you. We are a mission-driven industry. The folks that work in our supply chains are not being paid as well as the folks that work in industry supply chains. So
Yeah.
we do the work because we realize that the folks that are at the receiving end of our finished product are people that need to have care. Jane, thanks so much for joining us. This has been a great conversation. I'm so glad that you took the time out to talk with us. And be sure to join us next week when we will be talking with Lisa Rogowski from Trinity Health. Lisa runs the value analysis program, and I'm sure you'll get some great insights from our conversation with her. Thanks again, everybody, for listening to our podcast, Taking the Supply Chain Pulse. Subscribe, follow, and give us your comments for topics or improvements. And if you know some people that you think we should be interviewing, please tell us about them, too. I can be reached at fcrans, C-R-A-N-S, at stonge, STONGE.com. We'd love to hear from you. Thanks again. See you next time.